أنا أحب أشكر يعني أساتذتي وزملائي هنا في ليبيا. أنا بقالي يمكن 3 سنين يعني شغال في ليبيا عن بعد. أنا أول مرة أجي، فبصراحة شرف ليا إن أنا أكون موجود معاكم النهاردة. طيب نبتدي. The role of CMR in management of congenital heart disease. Agenda. We'll give a review of cardiac MR and cardiac or role of cardiac MRI in congenital heart disease. At first, CMR is an advanced imaging modality with important clinical applications. It has become established technique for anatomical, functional, and tissue characterization. There are specific challenges with the imaging of cardiovascular system, notably rapid and complex movements of the heart, the effect of respiratory motion, and fast high volume blood flow. Techniques as ECG triggering, gating, breath hold, imaging acquisition, respiratory navigation, and so on, made it
حسب الدرجة.
Okay, help us to overcome these challenges. CMR protocols should be tailored for every patient to answer the clinical question. So, a good referral is a key for a clinical useful CMR study, allowing the CMR department to optimally plan the examination ahead of time. We'll give a review on the sequences or images we use in the CMR. The first is the localizers. We use localizers for planning for our study to ensure the patient on the table, and it gives us some diagnostic value, especially for extracardiac structures. These images are in sagittal, coronal, and axial images. Okay. From these images, we can reach the planes of the heart. Okay. Short axis, 4 chamber, 2 chamber, 3 chamber, and so on. Then T1 and T2 images or black blood images. We usually use black blood imaging for tissue characterization. Another type of black blood imaging is the T2 star. T2 star we use to quantify the deposition of the iron in the myocardium and liver, especially in cases of chronic hemolytic anemia as thalassemia. Okay. The next one is the cine images. Cine imaging, by fast imaging techniques and ECG gating, a series of images are acquired during different phases of cardiac cycles. These images are then used to form a movies for the beating heart in different planes. What data can we acquire from these scenes? At first, the size of the ventricle by qualitative assessment, the function of the valve, is there a valve lesion? Is there any filling defect or masses? Is there a hypertrophy of the muscles? Or regional wall motion abnormalities? In this case, we can see the regional wall abnormality and a filling defect inside the left ventricle. We can use these images for quantitative assessment of cardiac volumes and functions. We can draw the endocardium of the left ventricle and right ventricles in the short axis by Simpson methods to get the end-diastolic and the end-systolic volumes and then the stroke volume. By correlating these values with the body surface area, we will get the index values. The phase contrast imaging or PC images. It is considered the duplex of the CMR. We use it for assessment of moving fluids, the velocity, the volumes, direction, and for measuring the QP/QS. phase contrast velocity encoding needs a regular rhythm to get sound data. Okay? If the case is has an arrhythmia, so the acquired data will not be correct. How to use it? In two perpendicular planes for the desired vessels. In this case, we have the aorta in two perpendicular planes. We put our plan on the desired area. It should be perpendicular on the vessel to get a through plane picture. This sequence consists of three images. This one is called the anatomy, magnitude, and phase contrast. By placing an ROI on the desired vessel at any of these three sequences or images, we will get the flow curve and the forward flow, the backwards flow, and the net flow. Okay? And at the end, we will get the regurgitation fraction. Perfusion imaging, we use it usually with the masses to assess its vascularity, and in stress imaging, on perfusion stress imaging. Late gadolinium enhancement is a special type of sequences called inversion recovery. We use it to null or to make the myocardium black, so the enhanced scar will be visualized clearly. In this case, that's a late gadolinium enhancement with a or nearly transmural scar, which is enhanced. In this one, there is a subendocardial scar in the inferior wall tuchus. T1 and T2 mapping are advanced techniques for tissue characterization, usually used in cases of cardiomyopathies. They will visualize the interstitial abnormalities like fibrosis, like wide extracellular space, and will measure the myocardial edema, the presence of myocardial edema and its extent. So these are our usually used sequences. Now we go for cardiac MR in congenital heart defect or congenital heart disease. We'll use it first for anatomy and segmental analysis, like these sequences. We can use it to get a 3D or a volume for the whole heart. We use it for assessment volume, functions, assessment of shunts, and measurement of QP, QS. And lastly, you can use it for tissue characterization in cases of infiltration or masses. With normal cardiac anatomy, there is a complete septation of oxygenated and deoxygenated blood. The two circulation runs in a series and maintain a one-to-one volume relationship on the systemic and pulmonary sides of the circulation. The deoxygenated systemic venous return to the right atrium is pumped to the lungs at the pulmonary blood flow, or QP. Once oxygenated, the blood returns via pulmonary veins to the left atrium and is pumped to the aorta as the systemic blood flow or cardiac output, or QS. The term shunt refers to an abnormal connection allowing the blood to flow directly from one side of the cardiac circulation to the other. Electrolyte shunt allows the oxygenated pulmonary venous blood to return directly to the lungs rather than being pumped to the body. A right to left shunt allows the deoxygenated systemic venous return to bypass the lungs and return to the body without becoming oxygenated. In each case, the circulation is less efficient and creates increased demand on the ventricles. In most patients, the volume of the shunted blood determines the severity of the symptoms. So QS equals blood pump to the systemic circulation and QP blood pump to the lungs. The ratio between these outputs is the QP-QS. So how to measure the QP-QS? At first, we will measure the ventricular end-systolic and end-diastolic volumes for each ventricle to get the stroke volume of each ventricle. I mean by stroke volume, in this case, the blood pumped by the left or right ventricle. Okay? Maybe this blood goes to the circulation or regurgitate via the mitral or tricuspid valve, or go to the shunt. Then we will measurement of flow across different vessels. We'll take our plane, in this case on the aorta for an example, get our through plane image, put our ROI or region of interest, then we'll get these data, net flow, forward, backwards flow, and regurgitation fraction for each vessel. In full study, we'll take our measures on the aorta, upper descending aorta at diaphragm, superior vena cava, inferior vena cava, main pulmonary artery, LPA and RPA. And we will get the list of measurements for every segment we measure. In normal circulation, the blood pumped from the ventricle return back via superior inferior vena cava to the right side, and then right ventricle and to pulmonary veins, and so on. The blood goes from the aorta, our volume goes to the aorta, should become the same volume to superior and inferior vena cava. The blood pumped via pulmonary artery should go to pulmonary veins at the same volume. In this case, when we measure the stroke volumes of left ventricle, it will equal the right ventricle, equal the aorta, and pulmonary artery. Pulmonary artery will equal LPA plus RPA. The descending aorta at diaphragm will equal the IVC. The blood goes to the viscera and lower limbs, should go back to the circulation via IVC as the same volume. Okay? In case of valve lesion, like mitral Rugige, how can we measure the regurgitant fraction or mitral Rugige? We'll measure the stroke volume of left ventricle, which will equal the X, which is the circulating blood, and mitral Rugige or the regurgitant fraction. In this case, let's say it's 100 millimeters. Then we will measure the forward flow at the aorta. Let's say, in this case, it's 90 millimeters. So, the regurgitant fraction by the mitral valve will be 10 millimeters or 10%. In this case, we have mitral regurg and aortic regurg. How to measure? We will measure the mitral regurg by the same way, but the aortic regurg, we will get it directly by flow data as the aorta. So the aortic regurg equals aortic backwards flow from phase contrast imaging at the aortic valve. Let's take a case for an ASD. The shunted blood from ASD will go from the left atrium to right atrium, right ventricle, then to pulmonary artery, and then goes back to the left atrium. So the left ventricle measurement will equal X. Right ventricular stroke volume will equal X plus A. Aorta will equal X. Pulmonary artery will equal X plus A. So the ASCD will equal, we have one unknown value, which is the A or the ASD. We can get it by pulmonary artery minus aorta, or right ventricle minus left ventricle. And QPQS will equal pulmonary artery by aorta. Let's take an example. If the aorta, measurement of aorta was 40, measurement of the pulmonary artery was 50, so the ASD shunted volume will be 10 millimeters, and QPQS will be 50 by 40, which is 1.25. Another example with VSD. There is a trick with the VSD. Shunting with the VSD usually occurs with systole. The blood goes from left ventricle to the pulmonary artery directly without being accommodated in the right ventricle. So any measurement of the right ventricle will not contain the shunted blood volume. In this case, the left ventricular stroke volume will be X plus V or VSD. Right ventricle will equal X. What do you think? In this case, we have ASD, VSD, mitral regurg. Can we measure it? Left ventricular stroke volume will contain mitral regurg, VSD volume, shunted volume, and X. Right ventricular stroke volume will contain ASD volume plus X. Pulmonary artery flow measurement equals ASD plus VSD and X. Aorta flow will equal X. We have how many unknowns? 3 unknowns, which are the mitral regurg volume, the VSD volume, and ASD volume. But we have, okay. But we have an example in this case. We have X, which is 60 millimeters. We can get the ASD. RV minus aorta equals 20 millimeters. Pulmonary artery minus aorta, which is known now, will be 30 millimeters. And we will get the mitral regurg by usual way. QPQS will be pulmonary artery by aorta, and will equal 110 by 60. خلاص قربت خلاص. طيب, how to measure the mucus volume? As I said before, the volume going to the aorta or systemic circulation should equal the volume returning from the systemic circulation. So the aorta at normal should equal superior vena cava plus inferior vena cava. In this case, some of this blood will go directly to the pulmonary. So superior vena cava plus inferior vena cava will be less than the aorta. QPQS will be pulmonary artery flow plus mucus volume by the aorta. In cases of Glenn, sometimes a collateral develops between the superior vena cava and inferior vena cava, which is in cases of failing Glenn. with no collaterals, the blood goes to the lower limbs and visceral, should equal blood coming back from lower limbs and visceral. In this case, there is no collaterals. But with collaterals, some blood will escape the superior vena cava to inferior vena cava to come back in the IVC, and the forward flow in the aorta at the diaphragm will be lesser than the backward or coming flow from viscera and lower limb at IVC at the same level. The venous collateral volume will be, in this case, 5 millimeters. There is a special sequence. We can follow the contrast against time. We inject contrast at the right brachial vein. It should go to the superior vena cava, then to the pulmonary arteries. In cases of venovenous collaterals, some of this contrast will escape to the inferior vena cava via these collaterals. Take-home message. CMR protocol should be tailored for every patient to answer the clinical question. A good referral is a key for clinically useful CMR study. CMR is a powerful tool for assessment for congenital heart defect, including anatomy, function, and tissue characterization. Regular heart rate is a must to get sound flow volumes. Providing anatomical data of the patient's congenital heart defect will help in planning of the CMR hemodynamic study. Thank you.
Thank you very much. Thank you. It was very excellent, and you make it very easy, actually, very basic.